جميل جدا، بسم الله. دي الارتكل رقم 4 النهارده، البوست منوبوزال اندومتريوزس. اتفضل يا دكتور مصطفى.
تمام. endometriosis uh, postmenopausal endometriosis clinical insights and imaging considerations. Endometriosis is an endometrial-like tissue outside the uterus. It is a chronic, systemic, and progressive disease associated with fibrosis and multiple inflammatory effects, driven mainly by estrogen stimulation, especially in post-menopausal female. Postmenopausal, defined as a cessation of menses beyond 1 year since the last normal menstrual period or last menstrual period. Postmenopausal endometriosis is less common, less active than premenopausal disease. But on the other hand, it carries a high risk of malignant transformation. Mechanisms of postmenopausal endometriosis. There are four main mechanisms, starting with reactivation theory. هيبقى عندنا endometriotic lesions formed during premenopausal years, وممكن to persist into postmenopause. Despite lower energy levels at post-menopausal women, these lesions maintain biological activity and responsiveness to estrogen. السبب في ده إن هي بيبقى لسه موجود فيها there's estrogen and progesterone receptors retained within these lesions. The activation or reactivation can be triggered by external or internal. يعني external from hormonal therapies given to the female or endogenous estrogen production through systemic disease. The next theory is the de novo theory. Endometriosis may persist post-menopausal without prior disease through mechanisms like genetic mutation, resistance to progesterone, and defective apoptosis. Local estrogen synthesis by endometriotic lesions, particularly through overexpression of aromatase enzyme, plays a role in self-sustaining disease progression. Others include peripheral aromatization in adipose tissue, ovarian remnant syndrome, or estrogen secretion or secreting tumors. Hormonal replacement therapy, especially unopposed estrogen therapy, is a significant risk factor for postmenopausal endometriosis, with leading cause for malignant transformation and recurrence. The fourth one, local estrogen production, even in low systemic estrogen states. Lesions can locally synthesize estrogen to promote disease progression via autocrine and paracrine effects. This mechanism suggests a complex interplay of persistent, recurrent, or new disease processes influenced by hormonal and genetic factors. Clinical presentation of endometriosis, symptoms similar to premenopausal endometriosis but less severe. Common symptoms are pelvic pain. يعني ممكن تكون stationary or worsened with age. Deep pelvic pain during intercourse, referred as dyspareunia. Pain during bowel movements, ischemia. Lower back pain or vaginal bleeding. Symptoms may mimic age-related conditions like vaginal atrophy or degenerative disc disease. Diagnosis occur during imaging or surgery for related issues, can be incidentally. Some patients with no history of endometriosis may develop symptoms post-menopause. التريتمنت اوبشنز الاوبتيمال او البرايمري option is the surgery, removal of all visible lesions, total hysterectomy with bilateral oophorectomy, removal of ovaries and fallopian tubes, salpingo oophorectomy. During surgery, it's also relieve persistent symptoms. The next is medical aromatase inhibitors, which block estrogen production in endometriotic lesion, reducing symptoms and the size of lesions. Next is the hormonal therapy. Combined estrogen and progesterone therapy may lower risk of recurrence. Surveillance, asymptomatic patient or with mild disease may only require regular imaging to monitor lesion. Individualized approach. Treatment is tailored based on patient age, symptoms, lesion characteristic, and overall health. Protocols, we have ultrasound and MRI for imaging. Ultrasound is the first line tool for detecting ovarian endometriomas and also endometriosis, with dedicated protocols identifying the deep lesions with high accuracy. Patient preparation and techniques. In preparation, we use laxative and bowel cleaning before examination to reduce interference for the transvaginal ultrasound. Mild bladder filling, improve visibility during the scan. This is for transabdominal ultrasound. Technique abdominal ultrasound is useful for evaluating lesions in abdominal wall, umbilical scars or area not accessible with the transvaginal probe. Transvaginal ultrasound involves multi-compartment analysis to comprehensively assess all areas within the pelvis. Second, MRI, of course, it's superior in resolution for identifying deep lesions, assessing risk of malignant transformation. البروتوكولز now used يعني in multiplanar يعني non-fat suppressed T2, fat suppressed T1, post-contrast T1 with subtraction, diffusion weighted imaging to evaluate lesions suspicious for malignancy and also ADC. Patient preparation for MRI, bowel preparation, benedi oral laxative, and rectal enemas with in cases with mild rectal distension, we use saline gel as an option to improve visualization of rectosigmoid lesions. Bladder distension, bladder should be partially filled to enhance visualization without causing discomfort. Vaginal distension, approximately we use 40 ml of ultrasound gel introduced into the vagina using a small catheter. This improved the detection of lesions involving the vaginal wall and fornices. Antiperistaltic agent, glucagon or hyoscine, can also be used to suppress bowel motion during the scan. The preparation, these are the preparation, ultrasound and MRI, and the purpose for each. Comparison of imaging finding in premenopausal and postmenopausal women. In premenopausal women, endometriomas, typical pattern and coexistence with follicles and functional ovarian cyst. At the postmenopause, the typical finding can be thick fibrous capsule, lack of peripheral follicles, or functional cysts. Deep endometriosis lesions in premenopausal بيبقوا شبه يعني look like nodules or plaques with smooth either irregular contour, cystic components with or without hemorrhagic content. On the other hand, at postmenopausal women, nodules are fibrotic or plaques, predominantly solid with retractile or spiculated margins with or without cystic components. There is also associated adhesions of the adjacent pelvic structures became more progressive or marked at post-menopausal women. Uterus, they look normal at premenopausal period, and zonal anatomy, endometrial pattern showing cyclical variation according to menstrual cycle. However, at post-menopause, the volume is less with loss of zonal anatomy and thinning of the endometrium. Typical and atypical imaging finding. الtypical imaging finding احنا قلناها في البوست menopause as a classic endometriomas, adhesions and uterus. الاندومتريومز بيبقوا ground glass cystic lesions on ultrasound. ال MRI T2 shading, T1 hyperintense with thick fibrous capsule. Adhesions, they predominantly within the Douglas of pouch, pouch of Douglas, pelvic facial retraction, anatomical distortion, and also there's a kissing ovarian morphology. The uterus is atrophic, less zonal anatomy, and thinned endometrium. الاتيبيكال فايندينج اي حاجه مختلفه عن التيبيكال بيبقى فيه cystic spaces with hemorrhage. ده في الالتراساوند بيبقى هايبو ايكويك. الام ار اي التي 1 بتبقى هايبر for the hemorrhage. With also the next one is typical endometriomas. بيبقى فيه internal septi, fluid levels و blood clots. Polypoid endometriosis ultrasound shows variable findings, honeycombing appearance. T2 MRI, there is a hypo-intense peripheral rim, variable restriction diffusions, T2 hyperintensity with post-contrast enhancement mimicking malignancy. Therefore, biopsy is required with close surveillance. ده منظر ده عندنا pelvic ultrasound showing adhesions. There is the ligament, utero rectal ligament. There is adhesions posterior to the vagina, and within the MRI T1 and T2. Atypical finding, there is also a lesion at the left aspect of the uterus and shows mild contrast enhancement, and also there is increased vascularity with Doppler ultrasound. Malignant transformation, EMT, when benign endometriotic lesion transform into cancerous tissue, بيحصل في about 22.5% in women with endometriosis. Postmenopausal women face higher risk due to prolonged hormonal exposure or latent disease. الريسك فاكتورز فيه هرمونال، زي ما قلنا احنا قلنا على الهرمونال ريبليسمنت ثيرابي or unopposed estrogen therapy. Progesterone only therapy not consistently protective، وبرضه ممكن برضه تسبب endometriosis. Lesions characteristic: larger ovarian endometrioma أكتر من 9 سنتي shows a higher risk of malignant transformation. Atypical endometriosis refers to percutaneous changes زي السيرور اتيبيا والاركتكشر abnormalities in the lesion. Next is genetic and molecular changes in genes ARID1A and HNF1 beta. Oxidative stress from iron deposits in endometriomas can also cause DNA damage. Surgical history: incomplete excision of endometriotic lesions or ovarian remnant syndrome, hysterectomy or salpingo-oophorectomy without full disease clearance and without complete resection of the previous endometrioma or endometriosis. Others في بقى اللي هو الانفلاميشن pelvic inflammation with endometriotic lesions والobesity لأنه بيبقى معاه peripheral estrogen production in adipose tissue. Malignant transformation عندها there are major types is ovarian malignancies or extra ovarian malignancies and also there are rare types. Ovarian are the most common with subtypes endometriotic adenocarcinoma, clear cell carcinoma. Extra ovarian malignancies بتبقى موجودة في pelvic peritoneum, bowel, vagina, less commonly abdominal wall and liver, often associated with deep infiltrative endometriosis. Rare types polypoid endometriosis بيميمك المalignancy but require biopsy for confirmation. Imaging features of malignant transformation. MRI is the gold standard, especially with contrast for detecting small or subtle solid components and assess lesion size and changes. Ultrasound commonly used initially for evaluation. MRI findings بيبقى في findings تبقى specific في malignant transformation. T2 shading loss indicate replacement of hemorrhagic material with tumor tissue, solid components as mural nodules or papillary transformation, early enhancement on post-contrast images, restricted diffusion, high signal on diffusion weighted image with low ADC. ده معناه ان فيها hypercellularity or diffusion restriction. Cystic changes, increased size or irregular shape of cystic lesions. الحتة بس اللي هي المهمة برضو اللي هي ال early enhancement ان المفروض النورمال اندوميتريوم لو في cancerous بيشو less enhancement than normal endometrial enhancement in MRI. Ultrasound finding, ground glass echogenicity replaced by irregular or heterogeneous internal echoes, increased vascularity of solid areas on color Doppler ultrasound. Third, extra ovarian sites as bowel or pelvic peritoneum. بيبقى فيه loss of T2 hyper intense mucosal cap اللي هو المشروم كاب. بيبقى فيه infiltrative growth pattern والadhesions and fibrosis with associated mass-like lesions. في حاجة اسمها Samson criteria. A malignant lesion can be considered to be originating from a focus of endometriosis if لو endometriotic or endometriosis foci found near the malignancy for a malignant lesion to be considered as originating from endometriosis. Exclusion of other primary cancer sites, no evidence of different primary origin for the malignancy should be found elsewhere in the body. Histologic examination showing possible origin endometriosis. ده منظر malignant transformation. دي female came with ascites. اتعمل لها peritoneal fluid cytology. Revealed high grade serous carcinoma of Mullerian origin which is very common associated malignancy with endometriosis. والليجن موجود on the left side. Clinical presentation. الsymptoms بتاعت malignant transformation mimic benign endometriosis but also بيبقى في البين طبعا غالبا بيزيد or persistent. New onset symptoms like bowel obstruction or vaginal bleeding, an infiltrative tumor, adnexal mass detected during routine imaging or surgery. Management, of course, is the surgical intervention is the first line for due to cancer risk. Radical excision of lesions, often combined with hysterectomy and salpingo-oophorectomy. في بقى non-surgical options for patient unable to undergo surgery، بيبقى زي ما قلنا قبل كده aromatase inhibitors reduce ال estrogen levels و close follow up. detection and surveillance recommendations. detection methods زي ما قلنا ultrasound is the first tool to identify cystic cysts or lesions. Shows also high sensitivity with Doppler زي ما قلنا الصورة قبل كده. ال MRIs offers more detailed views for the lesion, localization, size, and characteristics. Surveillance guidelines, high-risk patients, such as on hormone replacement therapy, as in breast cancer, or with large or atypical cyst, have regular imaging follow-ups is recommended. Suggested intervals 6 months for lesions with suspicious features, every year or annually for stable asymptomatic lesions. Any change in size or structure requires immediate re-evaluation, preferably with MRI approach. There's patient-specific monitoring is important with decisions made based on risk factor and imaging finding. ده آخر حاجة. detection of post-menopausal endometriosis. If suspected on the basis of ultrasound, we perform MRI next. ال MRI with risk assessment to be made. First benign features ده قلنا بنعمل annual MRI or ultrasound or combined. وبنعمل follow up per local practice preferences. Second atypical features بس ال patient not going for surgery or not candidate for surgery, repeat MRI in 6 months. Refer the patient for gynecological oncology evaluation. Third, features highly suspicious for malignant surgery or oncologic treatment. وده الكونكلوجن زي ما قلنا endometriosis is a chronic condition primarily driven by estrogen which persists in post menopause and also shows recurrence. In postmenopausal women, endometriosis is less active than premenopause, typically more fibrotic and often regress. However, it carries a higher risk of malignant transformation. Role of imaging critically for identifying, monitoring, managing lesion. MRI is preferred over the ultrasound in detecting malignant changes. Malignant transformation is a significant concern, especially with hormone therapy or large atypical lesion. With early detection and appropriate treatment, including surgery, are crucial for favorable outcomes. Future needs more research is needed to improve guidelines for managing postmenopausal endometriosis. Thank you.
تمام تمام، شكرا جزيلا يا دكتور مصطفى.
العفو.
طيب هنخرج يا شباب وبعدين ندخل نشوف الارتكل اللي بعد كده.